With Smyth from the Royal Marsden is talking today about GI tumors, which is a very wide field, and we'll see how she manages.
Thank you. So thanks to the organizers for asking me to speak today. I moved from the Marsden 3 weeks ago to Cambridge, although that's not on the program. So I'm a medical oncologist, and I was asked to speak about GI tumors today. And as Dr. Stahl says, the GI tract is very long, so I have omitted hepatobiliary tumors, although I will acknowledge that nivolumab is an active agent in that area, but I don't treat HCC patients, so we'll start at the bottom and work our way to the top. So first of all, I was asked to bring a case report. So this is a 55-year-old patient that we treated over the past year. He had metastatic HER2-negative gastroesophageal cancer, metastatic to the liver. We treated him with first-line ECX chemotherapy, and after 5 months, he had progressive disease. So in the context of a clinical trial, we started him on a PD-1 inhibitor. So unfortunately, at 8 weeks, when we scanned him, he had a progression of his major liver lesion of 55% and developed new liver lesions. And so what to do? Because he was on a trial and the protocol allowed and he was well, so we continued treatment for another 4 weeks. And fortunately, on the repeat scan, we had regression of the primary liver lesion and the new lesion. So it was a case of a pseudo-progression. And happily, he continued to have a response 6 months later. So I think this case demonstrates, first of all, that we do have some activity of immune checkpoint blockade in GI tumors, and second of all, that we do also observe pseudoprogression, similar to melanoma, similar to non-small cell. And in this case series we've just submitted, in just under 100 patients that we treated with immune checkpoint blockade over about 2 years, we observed it in just under 8% of patients. So I'll move on to colorectal cancer. So when we talk about colorectal cancer from the viewpoint of immune checkpoint blockade, we're really talking about 2 different tumors. The first is a minority of patients who have a high mutation burden, they're MSI high, or even ultra hypermutated with poly mutations. And the majority are microsatellite stable and have a low mutation burden. And of course, the efficacy of immune checkpoint blockade varies very substantially. It's effective for these patients, and these patients are completely immune evasive. So we'll talk about those separately. And, you know, colorectal cancer has really served as the archetype of mismatch repair deficiency when we're talking about immunotherapy. But there are a number of different tumors that display mismatch repair deficiency. Of course, studies like the one on the first slide overestimate the proportion who are mismatch repair deficient in the population that we want to treat who are metastatic because of the good prognostic effect of this. So in colorectal cancer, we see 3 or 4% who are mismatch repair deficient and metastatic, the same in gastric, and here also the other GI tumors, cholangio, hepatocellular, and pancreatic cancers. So the first paradigm-shifting trial was KEYNOTE 164. I'm sure you've seen this data before. Patients who had previously been treated with 2 lines of chemotherapy were treated with pembrolizumab, both in this case mismatch repair proficient and deficient tumors. And of course, you can see that the response rate was 57% for patients with mismatch repair deficiency versus 0 for those who were mismatch repair proficient. At that time, median PFS and OS not reached. And here in the mismatch repair proficient patients, we see a PFS and OS along the lines with what you would expect to see if they were untreated. So this caused a lot of noise both in the GI community and in a broader sense, and I think for once the hype was probably justified. This data has just been updated at Barcelona, presented last month. So you can see here we have reached a median progression-free survival, but if patients have not progressed within 6 to 8 months, they're likely to maintain a response, and the OS data is still median overall survival not reached. So really excellent outcomes for patients. Of course, based on this, FDA licensed pembrolizumab in a tissue-agnostic manner in May 2017. And again, we have been talking about EMA decisions, the EMA lagging somewhat behind on this. So reasonable question, is nivolumab equally effective in MSI tumors? And nivolumab has been assessed in CheckMate 142 only in mismatch repair deficient tumors. So in this cohort that was presented, that's just been published in JCO this year, 74 patients, two cohorts. The larger cohort previously treated with all the available chemotherapy drugs, so this is oxaliplatin, irinotecan, 5-FU. The second smaller cohort treated with fewer lines of chemotherapy. So clinical pathological characteristics, as you might expect, and about 40% of patients having a diagnosis of Lynch syndrome. So Lynch syndrome, important because we think that patients who have Lynch syndrome MSI tumors are much more likely to have, well, first of all, they do have a better prognosis, but may be more likely to respond to immune checkpoint blockade than those who have a sporadic MLH hypermethylation. So looking at the response rate, it was pretty much what we saw with pembrolizumab responses in 34% of patients, although about 60% had some shrinkage of their primary tumor. And again, the median progression-free survival and OS reflecting the tail of the curve effect that you'd expect from an effective immunotherapy. Interestingly, and this speaks to other tumors as well, patients who had fewer lines of chemotherapy did better with respect to both progression-free and overall survival, suggesting that this is going to be more effective when we move it into earlier lines of therapy. So if there's a take-home message for anti-PD-1 therapy in mismatch repair deficient colorectal cancer, is that it's effective for most patients and results in good long-term outcomes. So that's the results of both the pembrolizumab and the nivolumab studies there. So very reasonable to consider the addition of anti-CTLA-4 therapy. We've seen today how this has moved the goalposts or moved the boundaries in melanoma and lung cancer. So the second cohort of Checkmate 142 involved both nivolumab and ipilimumab. It's really important to note that these were not supposed to be compared, although they are constantly. So what we see for the combination therapy is that of 119 patients treated, that the response rate was 55%, so it is higher than what we saw with nivolumab alone. And the responses were equivalent across all biomarker subtypes, regardless of PD-L1 status. And there was a suggestion that patients with Lynch tumors did a little better, although they were excellent responses in non-Lynch tumors as well. So again, although these are not supposed to be compared, they did put them on the same KM curves. So you can see here that patients treated with dual immune checkpoint blockade did have a better progression-free survival, although we're not allowed to compare them formally, and a slight improvement in overall survival. So this is not yet licensed, but we might consider that the toxicity, as you might expect, was an issue, and about 20% of patients treated with combination therapy had a serious treatment-related adverse event, 10% discontinued treatment as a result. So something to consider if this moves forward. So we have been, I've just touched on MSI tumors, but you know, as I said, those really only represent a very small minority of the tumors that we see in the clinic. So what we see are 96 to 98% microsatellite stable tumors. And of course, across multiple clinical trials, there have been negligible responses to PD-1 inhibitors and PD-L1 inhibitors in these patients. So really, moving forward, we need to understand why this is, and we need smart combinations to help these patients respond to immune checkpoint blockade. So in terms of subcategorizing patients with colorectal cancer, probably the best transcriptomic categorization that we have is the consensus subtypes. And CMS1 is really reflected by MSI. We can also categorize them from a genomic or an epigenomic perspective, but this really encompasses all the MSI tumors. CMS2 has many characteristics which would be associated with immune exclusion, such as high Wnt pathway signaling and high copy number alteration. CMS3, or metabolic, has high RAS or MAP kinase pathway activation, and CMS4 also has high copy number changes, but it's really distinguished by the fact that it's very high in anti-angiogenic factors, stromal infiltration. And so how this reflects on the immune environment is that CMS1, as you might expect, has a very high immune infiltrate. This is all CD8 positive lymphocytes. CMS4 also has a high immune infiltrate, but these are the bad guys. This is the macrophages. It's a very immunosuppressive environment. And CMS2 and CMS3, as you can see here, no immune infiltrate. They're completely immunologically bland tumors. So how might we target it? What is at the basis of this, and how might we target it? Well, if we take the CMS2, which is high in Wnt signaling, certainly, and high in copy number changes, certainly copy number changes have been associated with immune evasion in melanoma. We know that patients who have high copy number changes are less likely to respond to ipilimumab. If we look at the Wnt pathway, so this is one of the larger studies which has just been published in Cancer Discovery. What they did was they examined the Wnt signaling over 1,200 colorectal cancer patients, and if you look at the outputs of the pathway, maybe measured using axin 2 expression here, you can see that there's a clear correlation between axin 2 expression and a decrease in CD8 infiltrate. Similarly for beta-catenin expression in the nucleus. So this has also been demonstrated in melanoma. The problem with Wnt signaling in colorectal cancer is that it's intrinsically linked to APC mutation for most cancers, and this is downstream of where most of the Wnt inhibitors are working at the moment. But there are a few downstream inhibitors of Wnt signaling, such as porcupine inhibitors, which will be coming online fairly soon. So we hope that this might be more effective for these type of tumors. So this is one we had great hopes for, and I know which was touched on earlier today. So CMS3 are MAP kinase pathway active. They're quite RAS mutated. And we know that MEK inhibition increases CD8 positive T cell infiltrate. We know that it increases MHC1 expression. And we also know that there is synergy between MEK inhibition and anti-PD-1 therapy. So based on this, we had great hopes for the initial MEK inhibitor plus atezolizumab trial in colorectal cancer. The first time this data was presented at ASCO 2016, the response rate was 17%, and everybody was overjoyed. The second time this data was presented from the early phase study, which was at ASCO GI this year, the response rate was 8%. So this might have slightly moderated our expectations for the phase 3 randomized trial, which was just presented in Barcelona last month. So this was the IMBLAZE 370 trial. Patients were randomized between atezolizumab, regorafenib, which would be the standard of care here, and also the MEK inhibitor cobimetinib and atezolizumab. And as you can see, there's absolutely no effect of the combined MEK inhibition and PD-L1 inhibition in colorectal cancer, unfortunately. And the response rates were between 2 and 3% for every agent that was tested. There was no subgroup effect. So these results were very disappointing, and I think it probably put an end to experimenting with MEK inhibition with PD-L1 inhibition in colorectal cancer. And lastly, in terms of CMS subtypes, this is something that has been discussed earlier today. So in terms of the CMS4, they are very TGF-beta activated. So there's an ongoing clinical trial looking at the Merck antibody, which is a dual targeter of TGF-beta and PD-L1, and we'll be looking forward to seeing the results of that. So this was touched on already today. I'm also a big fan of CEA, of bispecific antibodies. So CEA, as you all know, is something which is expressed on most GI tumors. So this is a bispecific antibody. One part joins to CEA, the other joins to a CD3 positive T lymphocyte. They come together, they lyse the cell. Lysing the cell introduces interferon, which upregulates PD-L1. So this provides a rationale to combine it with a PD-L1 inhibitor. So these are the results of the CEA bispecific antibody, which was evaluated both as monotherapy and in combination with atezolizumab. These results caused a lot of excitement when they were presented. The monotherapy efficacy is modest. I think response rates were about 6%. The disease control rate for the combination was quite impressive. So this was involved in a larger trial, which was open to recruitment. There are a few unexpected toxicities, which I think that they are dealing with at the minute, but certainly something that we're very interested to develop in future. So I think, in summary, for colon cancer, we've got two very different diseases. We've got MSI-high colon cancer, which is racing ahead. If we could get approval for this within Europe. Combination immune checkpoint blockade increases the efficacy, also adds to toxicity. For the majority of patients who are MSS, we're moving much more slowly, and I think really evaluation of the biology of the colorectal cancer and smart combinations will be important to move the field forward. So I move on to somewhere where we've had more encouraging results over the past year, and that's gastroesophageal cancer. So 2017 was a really good year for patients with gastroesophageal adenocarcinoma if they lived in the United States or Asia, because we had approval for pembrolizumab or nivolumab in chemo-refractory patients. Unfortunately, the EMA has just made a decision to decline nivolumab for the same indication. So these are the results of the trials which led to the approval in Asia. So this is ATTRACTION 2. This is the first trial which showed a benefit for immune checkpoint blockade in gastroesophageal cancer. This was a large, randomized trial, primary endpoint, overall survival. The issue which the EMA had with this trial was it was conducted entirely in Asia. The patients, therefore, were predominantly gastric rather than gastroesophageal cancer, which is what we see in the UK. So it was a chemo-refractory patient population. And this is what we saw. Responses to single-agent anti-PD-1 therapy are modest, approximately 12%. But when they occurred, they were long-lived. Median duration of response is about 10 months. We saw responses in PD-L1 positive and PD-L1 negative patients. And so the bottom line was that nivolumab reduced the risk of death by 38%. It doubled 1 and 2 year survival. However, it's clearly not a home run when you compare it to the results in melanoma or non-small cell lung cancer, so a lot more work to do. And what about biomarkers? Well, with respect to the ATTRACTION 2 study, it's quite difficult to interpret the PD-L1 results. This was tested on 38% of the population. It was done retrospectively. They looked at PD-L1 on tumor cells only. Broadly speaking, the response rates and progression-free and overall survival were equivalent for all PD-L1 positive and negative patients. But we need to be very cautious in interpreting these because they're in quite small numbers. However, as a result of that, of these results in Asia, this has been licensed as a treatment for chemo-refractory gastric cancer, that's second line, third line and beyond, in a non-biomarker selected population. So, the story for KEYNOTE-059 is somewhat different. This is a very different trial. This is a multi-cohort, non-randomized phase 2 trial. The primary endpoint was overall response rate. So a similar population, except for the fact it was conducted primarily outside of Asia. It's an international trial and thus had more gastroesophageal cancers. However, most of the patients had a similar number of lines of treatment. So these results are very similar to what we saw in ATTRACTION 2. Response rate in a non-biomarker selected population, 11.6%. The only thing with the PD-L1 assessment for the pembrolizumab studies is that they've used a CPS score, which is assessing the proportion of tumor cells and infiltrating immune cells, which are biomarker positive. And this does seem to be, although we see responses in PD-L1 negative patients, it's a better discriminator of outcome than the methodology which was used in the BMS trial. So for patients who had a response to pembrolizumab in this study, the duration of response was longer. So if it's a question, a hot topic is if you had a choice, which would you use? Well, here I put up the waterfall plots for all of the 3 studies that have used PD-1 inhibitors in gastroesophageal cancer in the chemo-refractory setting, ATTRACTION 2, KEYNOTE-059 cohort 1, and the nivolumab alone arm of CheckMate 032. And as you can see, the response rates are identical, and in fact, the median overall survivals are identical. So it's not so much, so there's clearly a class effect here. And in terms of the biomarker with PD-L1 expression, there's a lack of standardization. One issue that we run into time and time again in gastroesophageal cancer is heterogeneity of biomarker expression. There's plenty of accumulating data to suggest that this is also going to be an issue for PD-L1. So we had 2 nice positive trials. We have also had some very disappointing results this year in gastroesophageal cancer. So IPILIMUMAB failed to improve survival compared to best supportive care in the maintenance setting after first-line chemotherapy. One of the challenges with this study is that the patients who received best supportive care, most of them received maintenance chemotherapy. However, the response rates were very low at 2%, that really reflects what was also seen in a tremelimumab trial. So I do think that single-agent anti-CTLA-4 is probably not an appropriate treatment for gastroesophageal cancer patients. Just in the past couple of weeks, we've had the negative results of the Javelin 300 study, in which the bar was raised very slightly higher by comparing avelumab to chemotherapy in chemorefractory patients. There was absolutely no difference in overall survival, and in fact, the response rates to avelumab were quite disappointing. They were 2% compared to 4% for chemotherapy. So one of the positive outcomes of that trial was in a post hoc analysis, if patients did not progress on avelumab, that their overall survival was better than with chemotherapy. So I guess it's just a matter of identifying those patients before we treat them. And really that analogy could be moved to KEYNOTE 061. So this was a global trial where pembrolizumab was used in the second-line setting versus paclitaxel chemotherapy. And so interesting, so it's a negative trial. The curves cross. So initially, paclitaxel was the clear winner. However, at a later stage, patients treated with pembrolizumab had superior survival outcomes. Because the curves cross, the assumption of proportional hazards is violated, so you really can't use standard statistical tests to say it's a negative trial. And they did a post hoc analysis to show that pembrolizumab-treated patients did have superior outcomes. However, that was not the primary endpoint of the trial. So we say it's a negative trial, and there are biomarker selected subgroups that I'll discuss in a moment. So I think in view of the really modest response rates associated with single-agent anti-PD-1 therapy in gastroesophageal cancer, combinations are going to be the way forward, whether those are with other immune checkpoint blockade entities or with chemotherapy. So the first trial that looked at this was CheckMate 032, and it used two combinations of nivolumab and ipilimumab. And so one of the combinations improved response rates in both PD-L1 negative and positive patients. This was with the high-dose ipilimumab, and this is the combination that was brought forward into the phase 3 randomized trial in chemo-untreated patients. And this is the survival from this study, which was just published in JCO last week. And I guess you could say possibly that has the edge in terms of overall and progression-free survival. However, unfortunately, and this really reflects on the fragility of patients with gastric cancer, a third of patients had serious treatment-related adverse events, 20% came off study on that combination. And in fact, that arm of the first-line study is closed to recruitment because of an excess of early patient deaths. So it remains to be seen whether those patients will benefit. However, they did close that arm. So one of the combinations that created the most excitement last year, albeit in 25 patients, was the chemotherapy plus pembrolizumab study, cohort of KEYNOTE 059. So in metastatic gastric cancer, as you know, responses to chemotherapy happen in between 30 and 45% of patients. Here, in patients who were PD-L1 positive, response rates were 70%. PD-L1 negative, not so enhanced. If we look at the survival, this is good, but I think we really need to see what happens to these patients in the long term. I think that there are a lot of patients who are censored there, and we really need to evaluate that at a later date. But in view of the toxicity which was observed for combination immune checkpoint blockade, the toxicity for chemotherapy plus pembrolizumab was acceptable. 3 patients stopped treatment on the study, and all of those were for chemotherapy-related toxicity. So hopefully the combination of anti-PD-1 and chemotherapy for us hopefully will have positive results, just as we've seen in lung cancer this year. So in terms of targeted drugs, we've seen some discussion about anti-angiogenesis already. Anti-angiogenic therapies, as you know, work in gastroesophageal cancer, and it's one of the major negative regulators of the immune response. There was a clear preclinical rationale to combine anti-angiogenic therapy with anti-PD-1 therapy in gastroesophageal cancer. So this was done in the JVDF trial. When pembrolizumab was combined with ramucirumab in the second-line setting, the response rates were not really more than you would have expected with pembrolizumab alone. And when they were combined without chemotherapy in the first-line setting, the response rates were Okay, but certainly nothing to write home about. However, what they have shown more recently at ASCO GI was a very nice median overall survival, which was not reached. So this is interesting, and this has moved forward into larger trials. So in terms of biomarkers, MSI clearly is something that should be evaluated in most patients if the drugs are available to treat them, if immune checkpoint blockade is available to treat them. What we see in MSI high gastric cancer, which is 4% of the population, is across the board with pembrolizumab in studies response rates of approximately 50 to 60%. These are the results from the second-line trial, a clear benefit to pembrolizumab compared to chemotherapy. With the KEYNOTE-061 trial in the second-line setting, although the primary endpoint was in PD-L1 selected patients using a CPS score of 1, that was ineffective. However, when they went back and looked at higher levels of PD-L1 expression, here a CPS score of 10 or more, there's a clear benefit to pembrolizumab. So this needs to be evaluated prospectively. In KEYNOTE-059, the T-cell inflamed signature was assessed, was evaluated. Certainly, it enriched for response and improved progression-free survival, but it did lack specificity. And the fact that more work needs to be done to develop biomarkers is just highlighted by this patient from KEYNOTE-059. So even when all the stars align, when the patient is MSI high, PD-L1 more than 20, high T-cell inflamed signature, they still don't respond to pembrolizumab. So certainly more work to do to evaluate biomarkers in this disease. Moving on, finally, to discuss what the interaction between immune checkpoint blockade and the TCGA subtypes in gastroesophageal cancer. Well, I think we've really touched on MSI and EBV, and those are the low-hanging fruit for immune checkpoint blockade. They have high T-cell infiltrate, high interferon gamma signature, but rare in metastatic patients. Diffuse gastric cancer is a bit of mystery, even to gastric cancer specialists. They're very genomically bland. They rarely express PD-L1. There's a hint that some subtypes may have a T-cell inflamed signature. But CIN, gastric cancer, really makes up the bulk of what we see here. So again, they are immune excluded because they have a lot of copy number changes. They have low transcriptomic immune scores, and in general are likely to be less responsive to immune checkpoint blockade. And this is work from the TCGA data set, which Dan Catenacci's group in Chicago has done. And as you can see here, these are our CIN cancers. This is what we see in Europe, and they are the most likely to be non-inflamed. They are the least likely, the lowest proportion of inflamed tumors, and they have the lowest interferon gamma signature. So interestingly, there are specific mutations that were associated with a T-cell inflamed phenotype. PIK3CA and ATM you can expect because those are associated with EBV and MSI tumors respectively. However, the RHO-A mutation and the CDH1 mutation are in diffuse gastric cancer. So mechanistically, I don't understand how that works yet, but certainly that will need to be evaluated moving forward. And I was interested to hear that HER2-positive breast cancer is associated with immune infiltrate, because in CIN gastric cancer, it's associated with the opposite. So those tumors are immunologically ignorant, as are the other amplifications. However, finally, though, this is work that we've done in Cambridge. This is, even within CIN gastroesophageal cancer, there are genomically described subtypes that may be more sensitive to immune checkpoint blockade. So we used whole genome sequencing, and we defined 3 subtypes, all of which would fall within CIN. And one of these, making up about 50% of tumors, had a high mutation burden and was associated with high neoepitope prediction and also immune infiltrates. So it's possible that even within that CIN group, which is immunologically evasive, there are patients who are more likely to respond to immune checkpoint blockade. So in summary, outside of Europe, anti-PD-1 therapy is a new standard of care for patients with chemo-refractory gastric cancer. We know the single-agent activity is modest. Biomarker work would suggest that higher levels of PD-L1 expression will enhance response. But I think really for most patients, combinations will be the way forward to really benefit from immunotherapy. Thank you.
Thank you, Elizabeth. It's very good that Switzerland is outside of Europe because we have approved NIVOLUMAB in this indication.
We're very disappointed.
Yes, I can imagine.
Yeah.
Are there questions to Elizabeth, Kevin? You can use this.
Yeah. So, given the fact that most of our, well, all of our gut bacteria live in our gut by definition, and the microbiome is shown to be important in all sorts of other responses, including melanoma, hematological diseases. What's known about the importance of microbiome on the lack of efficacy of MSS versus MSI, or is there no data on that?
Well, it's very difficult because in order to understand the differential, you need to have a single responder, and if there are no responders, you don't have a control to compare with. So this is the difficulty. So we know that, for example, Fusobacterium is much more important in right-sided tumors, but because we haven't understood what the impact of that is on any immunological immune checkpoint blockade efficacy, it's very difficult to hypothesize. In gastric cancer, we know that the methylation that's seen in the MSI high tumors, which are sporadic, is probably related to H. pylori. And in fact, H. pylori induces itself a state of kind of transient mismatch repair deficiency. Yeah.
Yes, Paul? Tom?
This time I'm coming.
You're very sportive. God.
Pembrolizumab seems to outperform other drugs pretty much everywhere. It's almost, you can almost pick your cancer, where pembrolizumab seems to either be at least look indirectly better, there's no direct comparisons, yet you've got data where your curves really cross at the beginning and pembrolizumab fails where nivolumab succeeds. It's kind of unprecedented in that respect. And therefore, it suggests that there's a lot of noise, or there are differences between the drugs, or there's something totally unique about what you're doing. I've got no explanation for your data, not your data, but the data in your field, and I've thought about it a great deal, and I'm wondering if you do.
But the curves cross for pembrolizumab in the second-line study versus paclitaxel. And nivolumab, there is no data for nivolumab in that setting. So I think the next trial will be probably nivolumab plus paclitaxel. But there is absolute equivalence of pembrolizumab results in nivolumab versus best supportive care. It's just when the bar was raised a little higher with chemotherapy that it became less effective in a really unselected population.
Well, thank you very much, Elizabeth. And we go to our last talk today.